Hi everyone, my name is Pete and I'm here to talk to you about ROTEM and TEG. This is a copy of a presentation that I've given at a course today. I thought it might be helpful to upload it to YouTube. I'm an anaesthetic registrar in Australia, and I'll be talking to you briefly about the historical context of ROTEM, talking a bit about how you interpret the test and how you run the test, the evidence behind it, and then very briefly touch upon some future studies that will be coming out in the next few years or so. I'll try and have this done in 25 minutes. It's a lot to cover, so I apologize that I've skipped over so many things to get that done. Some context first. Dr. Quick is an American doctor who was first credited with describing what became known as the APTT. This is a direct quote from his paper. He discovered that he had this test that he had invented. It was prolonged in liver failure patients and jaundice patients versus the normal population, and he was widely rejected. This research he could not get published initially. People didn't see the utility of it, and I think that we're in a similar age now with ROTEM. I think that there's a whole bunch of new novel anticoagulants coming out, and we're not really sure how to interpret these tests. Do you compare these ROTEM tests to anti-10A levels or to bleeding? There's a lot of research going on. So we're in a state of flux, and I think that things will become a bit clearer in the next decade or so. Although I will note that ROTEM has been around for a very long time. TEG was originally described in 1948, but at least in Australia, it's still relatively in its infancy. We're also in an era of patient blood management, or PBM. The National Blood Authority, in Australia at least, sets the cost of blood to be around about $400 for a unit of red blood cells. And previously, the state has been paying a third of that, and the federal government has been paying 2/3 of that. Now, this state cost is being devolved to hospitals increasingly around Australia. It's already happened in places like Queensland, where you could argue they're more ROTEM friendly, and that might be why. In Victoria, it's happening already. There's a pilot program underway where the cost is being devolved to hospitals, and Western Health is part of that trial. So they use that potentially increased cost to justify, or partly justify, their purchase of a ROTEM. So a few bits of semantics first. This is a ROTEM Delta, and this is a Sigma, the newer machine that just takes one blue tube. Pardon me. TEG is thromboelastrography, and ROTEM is rotational thromboelastometry. Some people simply call it TEM, but the same principles apply. They're all whole blood tests, and a catch-all for both, or for everything, is, say, point of care testing. So let's talk about actually running a test. So it's really quite remarkably easy. I'll just go back here. You just get a cartridge, you put it into the front of the machine, and it does its thing. You take a blue citrated tube, just an irregular blue INR tube, and then you put it into that cartridge. It's got a little pin in it. And then it runs, and it runs in wherever you like, in, say, recovery or your lab, and you can actually see the results live in real time happening in your theatre or wherever you are. Now, I just want to talk about bechamel sauce for a minute. Bechamel sauces are a delicious French white sauce that I find quite difficult to make. It needs to be just the right consistency. Can't be too thick, can't be too runny. It needs to have the perfect amount of butter, milk, and flour, or cryoplatelets, and fibrinogen to make blood. Just the right consistency. You know it's the right consistency for bechamel when you can see the bottom of your pan when you're mixing it around. But just imagine instead of doing that, you were to twirl. Instead of doing this, you were to twirl your stick around your wooden spoon and measure the torsion. In that example, it's very similar to ROTEM. And to take that a little bit further, just say you had a massive dinner party and you had this huge pot of bechamel sauce and you wanted it to be perfect for your guests. So to test it without spoiling the big pot, you take a sample and you put it in a pot. Put some butter in there. Take another sample. Put some milk in this one. Another sample. Put some flour, maybe a fourth one. That's 4 burners or 4 channels. And you mix them around and you find out the flour is what you're missing. So you add that to your big pot. That's essentially a 4-channel ROTEM. So each channel is a little bit like this. There's a pin and it spins in a cup of blood. And as the blood gets thicker, the torsion on the pin gets stronger. The pin is suspended by a wire. It's a spring with a ball bearing system in the rotem. So some people wheel it from theatre to theatre. It's a lot more resistant to vibration than the TEG system, where the cup moves and the pin is fixed. I mentioned you have 4 channels. These are these 4 channels. The XTEM you can think of basically is the intrinsic pathway. It uses tissue factor for activation. The INTEM is basically the intrinsic pathway. It uses ellagic acid for activation. The FibTEM has platelets taken out. So it uses cytocolecin D to kind of remove platelets from the equation. If it didn't, it would look like this. So you might see the platelet component, and you might see like an other component if they were labeled as such, if you could remove each piece. The APTEM is the 4th test, and the 4th test you get depends on the cartridge you use. So the APTEM, AP stands for apoprotein, and that's the same thing as basically adding TXA. So you can see what the effect of adding TXA would be in this test before you do it to a patient. The HepTEM, for heparinase, and you can think of that as basically the same as protamine. It allows you again to see in this test the effect of giving protamine without doing it in the real patient. Now, there's lots of variables, but you only really care about 3. The clotting time. So this is the time from 0 to a 2 millimeter clot, however long that takes. And it's colored green here by the rotor machine. The next one is the A10. A stands for amplitude. So I should mention we have amplitude here on this y-axis in millimeters. That's clot strength. And then we have time in this x-axis. So you could choose any time. You could choose an A5.5 or whatever. But lots of studies have looked at the A5 and the A10 as how predictive they are of the ultimate trace. And they've been found to be very predictive, about 97% predictive for the rest of the trace. So this allows you to make your decision faster without waiting for the rest of the trace. And the third one is maximal lysis, but I'll get to that in just a moment. So with these 3 variables, you can apply a 3-step process very simply to any trace. So number 1, clotting time. If it's prolonged, it suggests your answer is going to be FFP or heparin, depending on the HepTEM, at least in Australia. So rule of thumb. Let's just say 250 seconds is a rule of thumb for INTEM. This is just a rule of thumb. It's not accurate. So this is prolonged. Now, when we add heparinase or protamine, does it fix the problem? So now our clotting time has gone back down to a normal 202. So the problem here is heparin. Number 2, the A10 amplitude. Rule of thumb again should be more than 40. In the INTEM or XTEM, and more than 9, or some places use 10 in the FibTEM. So this A10 you can see here is 23 millimeters. So that's reduced. Now, is the problem fibrinogen or is it platelets? Let's check out the FibTEM. You can see the A10 is less than 9 millimeters or 10 millimeters. So the answer here is cryo or fibrinogen concentrate. Number 3, the maximal lysis. So this is the current amplitude versus the maximal amplitude that's happened to date. So at this point here, in 20 minutes time, we've only gone down ever so slightly from the maximum. At this point here, we've gone down by 40%. The cutoff is 15%. This is again just so that you can call this as early as it crosses that threshold, you can start treating. So this is an INTEM showing lysis, complete lysis in fact. And if you add apoprotein or TXA, does it fix the problem? And yes, it does. There's no lysis here. So the answer here would be TXA. Now, I'll just mention a few examples very briefly. So this number 1, let's apply our 3-step process. Number 1, what's the clotting time? Is the XTEM less than 100 seconds? Yes. Is the XTEM less? Is the INTEM less than 250 seconds? Yes, it is. Good. All right. So let's go to the A10. Just a little hint here too. The green line here is 40, so I can tell at a glance that this is fine. But anyway, the A10 is 50 here, the A10 is 50 here. The FibTEM, is it less than 9? No, it's good. All right, what's next? Number 3, maximal lysis. Well, there is no lysis at all, so that's fine too. So this suggests that this is a normal trace, but you have to take it back to the clinical context. It's always about the clinical context. So in a bleeding patient, this would suggest that there is no coagulopathic problem. The answer is then vitamin P or proline, i.e. it's a surgical problem. If and just the flip side to that coin is if you have a normal patient then who has an abnormal rotem but is not bleeding, then the appropriate course of action would probably be to just simply observe. All right, next example. So 3-step process, clotting time. It's less than 100 seconds for the XTEM. It's less than 250 for the INTEM. Good. Let's move on to number 2, the A10. The A10 is less than 40, so there's a problem here. Less than 40 on the INTEM. Problem here. Is it fibrinogen? No, the fibrinogen is good. It's more than 10 on the A10. So the problem is platelets. I hope that's clear to everyone. Now I'm going to skip over these examples. These are all from the ROTEM website. You can go look at them in your own time. If that doesn't float your boat, well, you may like the Drinker's Guide to ROTEM. So if you see a brandy tumbler, that's normal. If you see a wine glass, that's a prolonged clotting time. The answer might be FFP. If you see a champagne flute, then the answer might be platelets or cryo, depending on the FibTem. Excuse me. If you see a sideways martini glass, then the answer might be TXA, depending on the APTEM. So that's a bit about interpretation. Now I'd like to move on to talking briefly about the evidence. Firstly, what does the NBA say? What does the National Blood Authority say, not the National Basketball Association? They give it a very lukewarm grade C and only for cardiac surgery, unfortunately. This up the top here is their recommendation that TEG should be considered in the use in cardiac surgery. They also state in one of the modules that further research is desperately needed, and that's pretty much what Cochrane have said too. But let's come back to Brisbane. So can point of care be used as part of PBM to reduce blood product usage and cost? Well, the answer is probably. There's a case study that's on the MBA website. They put a lot of work into it. It's well worth a read. They have videos. It's at Prince Charles Hospital, and it's a similar size to RMH. They just found that they were routinely ignoring standard coagulation tests. They just took too long to come back, and they felt that they were empirically treating people, and there's a known risk of overtreatment with that and the risks associated with that. So they implemented a PBM that was hospital-wide, and this incorporated point of care, including into their massive transfusion process protocol. But I should say the PBM was pervasive. It was introduced at all levels, including pre-op. So when you came in preoperatively, you would get iron studies if appropriate, and you'd be treated if appropriate. So that's an important thing to keep in mind, because that could have that's a major confounder, is what I'm trying to say. So they looked at their data 12 months prior to the introduction, they introduced it, and then 12 months after the introduction. And this is their setup. So they had a ROTEM machine sitting elsewhere, and it was streamed live into theatre, into blood bank and ICU. These are 2 ROTEM machines, in fact, and this is a multi-platelet analyzer in the background here. This is a big part of the story, but unfortunately you don't have time to go into it today. This is their protocol. I'll just skip over it, except just to briefly mention that it's pretty much the same as what we were just talking about then. So if you have an XTEM that's less than 40, so that's step 2 of the process, and then your FibTem is less than 10, then the answer here is cryo or fibrinogen concentrate if you live in Europe. What happened? Well, not surprisingly, their blood product uses went down pretty dramatically, except for cryo, and they reduced their post-operative nosocomial infections, their post-op infection rates. That's not surprising either. Many other studies have shown an association between red blood cell usage and subsequent infection. There's also a trend towards lower mortality and a return to theatre for bleeding. These are just their results. These are the blood products, and this is the relative change. So you can see huge reductions in all products except cryo. They also put a price per unit on all those blood products and came up with the ultimate figure of about $1 million that they saved. Criticisms, well, there was no wash-in period. It's a bundle of care, much like the River study and Central Line, so it's hard to say what role point of care played in that. And it may have been just the PBM. And I think a great example of other stuff playing a more important role is this study by Goodnor, a hematologist in the US, who did this great little paper where all he did was introduce an extra form, just made it slightly more inconvenient for people to prescribe blood. And that one intervention alone resulted in huge reductions of transfusions, reduced length of stay, reduced mortality. It's pretty amazing. This MBA study wasn't powered to look at any specific outcome either, and there was a trend towards lower mortality anyway. You can see this is the introduction in the middle here, and it was kind of trending down anyway. Speaking of mortality, can point of care look at reduced mortality in other data? Yes. Well, it can. This is a similar setup in Colorado. It's a case control study, pre-TEG and post-TEG. TEG was incorporated into their massive transfusion protocol, and essentially they found a massive reduction in mortality, but and also blood product usage. But it wasn't powered to look at blood product usage. And please do note that 2/3 of the pre-TEG patients were severely injured. That's an injury severity score of 36. Only 1/3 of the post-TEG patients were that severely injured. So that alone could explain the difference in mortality. This is just to show you that in the kind of the bluish kind of color here and the kind of maroon kind of color, that's before and after TEG. You can see a drop in the blood product usage. It was just a feasibility study, really. It was a pilot study. It wasn't designed to look at. It wasn't powered to look at blood product usage, unfortunately. And the ISS, pardon me, score can explain the mortality difference. So, can it reduce FFP? Probably. This is a study from Houston, and I'll just skip it except just to say that they introduced. Well, actually, I'll just come back to it. It's a bit different. They were actually using TEG at this, I think it's the Ben Taub Trauma Center in Houston. They were using TEG way before the ratio stuff kind of became popular, and then they switched to the ratio stuff. So they did it the opposite way to most people. And anyway, they just looked at their case controls and found they were using more FFP without TEG. Can point of care testing reduce bleeding and transfusions? Yes, probably. This is one of the more statistically robust trials. This is in Kyoto. It's looking at cardiac surgery, and they had a fantastic protocol. I didn't want to spend much time on this, but I just want to briefly mention it. That they had protocolized post-cardiac or intracardiac surgery. If you had diffuse bleeding and your hep-tem-in-tem ratio was above a certain amount, you gave this much protamine, and then they protocolized the rest of it. Beautiful little study, and they found bleeding and blood product usage was reduced dramatically. So these are in mils per kilogram. So for a kid, this is a big difference. It's almost half, in fact. They almost had half the amount of bleeding out the chest tube in the ROTEM group, and they subsequently used less products as well. That is one of the studies that is included in this Cochrane review. They said maybe, essentially. So they looked at all these studies, and I'll just skip over to mortality. They did find a statistically significant reduction in mortality, but they still gave it a pretty lukewarm recommendation because the quality of the data was just so low, in their opinion, and there was lots of bias. Many of these studies are not controlled for in terms of their protocol. You could still be using standard coagulation test and ignoring the TEG or in some of these studies. So they wrote here, this is a direct quote, that we urgently need some more RCTs in this area to give us some more guidance. And that came out this year, so that's pretty topical. Now, I've got 5 minutes to go over the remaining some future studies. So this is a really interesting one, partly because it has a catchy name, Feisty. This is happening up in Queensland, and it's essentially a trial of the German model. It's giving either cryo or fibrinogen concentrate to trauma patients, but basing it on their ROTEM. And there are lots of potential theoretical advantages of fibrinogen concentrate. It's in powdered form. You can store it for ages. There's no viral risk. It's very low volume. You can give it very quickly in a very specific dose. So they're going to give it to trauma patients based on their ROTEM, their FibTem A5. And the point I'm trying to make here is that they're just assuming that ROTEM works just fine because so much research has been done into this particular bit. And it's a feasibility study they're going to do if it works. They're planning to do a bigger trial later. It's being used in liver transplant versus conventional Quag testing. This is an interesting one because of the main author, Karim Brohi. He's a very famous trauma surgeon in London, and he's looking at a very patient-centered outcome of 24-hour alive and free of massive transfusion. This is comparing ROTEM to regular coagulation protocols. It's also being used in PPH. So, in summary, it is, you can't really see it there, I'm sorry, it's hiding. It's hard to test a test. When you compare it, like a ROTEM outcome, to, say, anti-10A for testing for NOACs, the anti-10A is kind of supposed to be the gold standard at testing it, but it only looks at a very specific part of the coagulation, whereas the ROTEM looks at the whole blood. So if it doesn't correlate to the A10, does that mean it's not as good? I don't know. I don't know if that's the right thing to be comparing it to. Isn't bleeding the ultimate outcome? And it does make sense that you should make your decision based on a whole blood test rather than just a very specific plasma test that doesn't take into account other things like tissue factor or monocytes. There is good evidence for blood product reduction, and you would think that because other studies have shown that reduction in blood products leads to a reduction in mortality, you would think that you could link those two things together, but the research for ROTEM hasn't made that clear yet. And what are we left with? Well, an approach that's prudent might be to use a ratio-based approach initially in the very first stages, and until you can get point-of-care testing, and then you can individualize your care to that patient and that patient's specific needs. Now, that's a brief overview, but what do people much smarter than I think about ROTEM? Let's hear from Karim Brohi.
And we have it in our emergency department as part of a research program. We are essentially trying to come up with an evidence-based algorithm using an observational study before we actually use.
I hope that audio is coming through
to guide our clinical resuscitation. I think it's always going to be some sort of hybrid between an empiric treatment first off and then moving to a TEG guided thing. And how we actually do that is hopefully something that we'll have some beginning answers to within the next 12 months or so.
So just in case that audio didn't work for you guys, he's essentially saying that he sees it being a ratio-driven approach initially, and then moving to a point-of-care testing after that initial phase. This is John Holcomb from the Proper trial.
It absolutely was not, and we put this in the paper, that was not designed to look at goal-directed with TEG or TEM. I'm a strong supporter of the viscoelastic studies. They're a lot better than the PTT-INR studies. And we've certainly presented and published some of those data. We published in Blood recently with Par Johansen from Denmark kind of how we do it. And what we do is really a combination of both ratio and goal-directed with TEG. So not rigidly ratio-driven and not rigidly TEG-driven, because all the lab values take time to come back. In a patient who's rapidly bleeding, you need to call the blood bank and say, I need X amount of blood products. You can't call and say, send me whatever you think is right based upon the TEG. You have to tell the lab tech what to send. And so in patients rapidly bleeding, we start off at 1:1:1. When bleeding slows or stops, or lab values are coming back in an appropriate time frame to be physiologically relevant, then we can do goal-directed. So in a clinical scenario, that's right. What we do. In effect, in Proper, this.
All right, I'll leave it there. Just in case, again, you couldn't hear that audio, John Holcomb is essentially agreeing with Karim Brohi. All right, so that's about it. That was about 25 minutes, and thank you so much for your attention, and please hit me up on Twitter if you have any questions at all. Thank you.